Good morning all. On behalf of Sri Lanka College of Hematologists, I would like to welcome you all for the first Red Box of the year 2021. This Red Box will be presented by two clusters, Colombo NHSL and Faculty of Medicine Colombo LRH cluster and Teaching Hospital Ragama, Faculty of Medicine Ragama cluster. So to begin with, I would like to hand over to Dr. Madhuvanti from Ragama cluster to start with. Thank you.
Thank you, Dr. Manuri. Good morning, everybody. I hope I am audible. I cordially welcome all the consultant hematologists and our guest speaker, Dr. Rajitha Samarasinghe, consultant chemical pathologist at Apeksha Hospital, Maharagama, and also all the postgraduate trainees in clinical hematology to the phase 1 of Red Box, February 2021, a compilation of patients with paraproteinemia conducted by postgraduate trainees from Colombo North Teaching Hospital, Ragama, and Faculty of Medicine, Ragama. Here, 4 different case scenarios will be discussed by the trainees, and Dr. Samarasinghe will be giving her expert opinion on further investigations from biochemical point of view. On behalf of Ragama Training Cluster, I take this opportunity to thank Sri Lanka College of Deciders for their kind contribution to make this event a success. Now let's move on to the first case presentation that will be done by Dr. Lochini Dasanayake. Over to you, Dr. Lochini.
Thank you, Dr. Madhuvanti. Good morning to everyone. I am going to present a case of a yellow girl presenting with loss of appetite and loss of weight for 6 months duration and exertional SOB for 1 month. She was detected having a past history of multiple large joint arthritis 1 year back, but this has not been investigated. There was no history of oral ulcers or photosensitive skin rashes, no history of chronic cough, night sweats, or contact history of TB, no known past history of malignancies, no PR bleeding, melena, or menorrhagia. Her dietary history was not satisfactory. The family history was not significant, and she's an A-level student and the second child of the family. Mother was abroad until 1 year back, and she has been lived with grandmother. And on examination, she was cachectic and pale. There's no icterus, alopecia, oral ulcers, lymphadenopathy, thyrotoxic features, or clubbing. Her cardiovascular system, respiratory system, abdomen, and nervous system examination did not reveal any abnormality. These are investigation. In full blood count, she had hemoglobin 8.5, moderate anemia with low MCV, MCH, and MCHC. Her platelet count was normal and her retic percentage was 1.34. When it's corrected for her hemoglobin level, it was 0.77%, indicative of reticulocytopenia. This is a blood picture. Blood picture revealed hypochromic microcytic red cells with marked ruler formation. There was mild leukopenia normal. Her ESR was 143 and CRP was 6. This is iron studies. So serum ferritin was increased while serum iron was low and with low transferrin saturation. Total iron binding capacity was normal. And this reticulocyte hemoglobin content, which is a novel red cell parameter, was 19.1 picogram, which is low. All these are indicating anemia of chronic disease. Her HPLC was normal and her serum creatinine is normal, and AST, ALT, and serum bilirubin normal, with her serum protein showed increased globulin fraction with reverse screening was negative and marked to test negative. The chest X-ray, ultrasound abdomen, and 2D echo were normal. The serum protein electrophoresis revealed a low albumin band with a polyclonal increase in gamma globulin, and there was elevated alpha-1 and alpha-2 bands, but there were no abnormal monoclonal bands. They have suggested to exclude inflammatory process. This is a serum-free light chain assay. It revealed both increase in kappa and light chains, but the kappa lambda ratio was normal. This is also suggestive of polyclonal increase in gamma globulin. This is a bone marrow biopsy, which revealed hypocellular erythropoiesis for age with increased iron stores. There was no ring sideroblast. There was increased hemophagocytic activity with no evidence of increase in plasma cells, lymphocytes, or abnormal cells. This is an autoimmune screen. ANA was positive, and the DSD.
Can I disturb for a second?
While C3 and C4 levels were normal. At this point, arthritis.
Can you hear now?
Yes, I can hear you, madam.
Yeah, now. Yeah, this based on the history, basically based on the history, you would expect a polyclonal increase in the electrophoretic separation. Now, in my case, putting this as a polyclonal increase in gamma globulins, because you all can see the peak is little bit pointed. So there can be a monoclonal band hidden inside this. So in my case, personally, I would not confidently report this as a polyclonal increase. I would go and do a immune fixation electrophoresis after this to confirm. So here, instead of serum immune fixation electrophoresis, you all have done a urine electrophoresis and followed by a serum free light chain. But I think in this one, I would do following the serum protein electrophoresis, I would go to a serum immune fixation electrophoresis and stop then and there. I will not go for a even serum free light chains. Now, can I go to that serum free light chain report, yes, please?
This is a serum free light chain assay.
Yeah, here you all can see both kappa and lambda chains have gone up, and the ratio, keeping the ratio within the normal range. That is what we can expect from a chronic inflammatory reaction, because both kappa and lambda line chains increase but maintain in the ratio. So this is something that we can expect from a chronic inflammatory response. So in this case, ideally the investigation should be serum protein electrophoresis followed by a serum immune fixation electrophoresis.
Yes, thank you, madam. I'll start from this slide. And this autoimmune scan I mentioned earlier, the ANA and MT double-stranded DNA were positive, while the C3 and C of joint arthritis and leukopenia in full blood count, together with positive ANA and MT double-stranded DNA, the patient fulfilled criteria for SLE. This is a malignancy screening. Here the CA125 levels normal, but the CEA and CA 19.9 are still pending. We came to this diagnosis of anemia of chronic disease due to systemic lupus erythematosus. We managed this patient with 1 pint of blood transfusion since she had symptomatic anemia, and nutritional referral was done to improve the follow-up with regard to SLE. This anemia with high ESR is a very common reason for referral to hematologist. And we do serum protein electrophoresis in this patient to exclude a monoclonal gammopathy. A homogeneous spike-like peak in a focal region of gamma globulin indicates a monoclonal gammopathy. These are associated with clonal process that is malignant or potential malignant. And in contrast to monoclonal gammopathy, polyclonal gammopathies may be caused by any reactive or inflammatory process, and they are usually associated with non-malignant conditions. This table gives you the differential gammopathy. That can be seen in infections like viral infections, focal or systemic bacterial infections, and TB, and connective tissue disorders like SLE, mixed arthritis, and sarcoidosis. And also in liver diseases like cirrhosis, ethanol abuse, autoimmune and viral hepatitis, primary biliary cirrhosis, and sclerosing cholangitis. And also in malignancies like ovarian, lung, hepatocellular, renal, and gastric malignancies. This can be seen in hematological conditions like lymphoma, leukemia, and thalassemia and sickle cell anemia. The other inflammatory conditions which we can see polyclonal gammopathy are gastrointestinal disorders like ulcerative colitis and Crohn's disease, pulmonary disorders like bronchiectasis, cystic fibrosis, chronic bronchitis, and pneumonitis, and endocrine diseases like Graves and Hashimoto thyroiditis. These are my references, and thank you very much for listening. The next case will be presented by Dr. Tilini, who is a diploma trainee in clinical hematology attached to Ragama Hospital. Over to you, Tilini.
Thank you, Dr. Lochini. Moving on to case number 2. My patient is Mr. X. He's a 45-year-old driver from Gampaha area. He's unmarried and living with his younger sister. He's a diagnosed patient with congenital ichthyosiform erythroderma since childhood and was defaulted from follow-up for a couple of years. Last year, he presented to a medical unit with bilateral ankle swelling of 1 week duration. There were no symptoms to suggest cardiac or hepatic origin for this presentation. Though he did complain of mildly reduced urine output, there were no other urinary symptoms. On general examination, he was pale and there were bilateral picking ankle edema. Systemic examination was unremarkable. Moving on to investigations, his full blood count revealed a moderate anemia with HB of 8.9 and a mild thrombocytopenia. Blood picture revealed ruler formation. ESR was elevated 66 mm per first hour. Septic screening was negative. He had elevated serum creatinine levels 345 micromoles per liter, and UFR revealed trace amounts of protein. His urine Bence-Jones protein screening test was positive. His liver functions were normal. Albumin was within the normal range, and there were no reversal in albumin to globulin ratio. Ultrasound abdomen revealed bilateral chronic renal. 2D echo ruled out cardiac failure. His serum calcium levels were elevated 3.1 millimoles per liter. His serum phosphate levels were normal. This his skull X-ray revealed multiple tiny lytic lesions. These are his serum electrophoresis reports, which revealed a tiny monoclonal band in the fast gamma region with a background of suppressed gamma globulins, and on the right hand side is the immunotyping of the same. Rajita madam,
Yeah.
could you please comment on this report?
Yeah. Now in the electrophoresis, serum protein electrophoresis, there is a monoclonal band, but I can't say there is any immunoparesis in this one, because if there is a immunoparesis, you should see the other side of the spike. You should see it is coming down and touching the baseline, like in your albumin band. So this doesn't have a clonal band with a lot of background staining in this one. And typing is what you do. Antibodies to IgG, IgA inhibit the IgM. Those antigens are inhibited. The separation, you will not see the band if the antigen is there. So in this patient, you can see the standard or the sample. When you superimpose the sample with the inhibited sample, you will see there is the superimposed sample is matching with the inhibited one, except the lambda one. The lambda one, you have see there's inhibition, and the lambda one, if there is a it has come to the baseline. So there's a lambda light chain myeloma. This is a lambda light chain. Most of the light chain myelomas in the normal serum protein electrophoresis, you will not see a monoclonal band. Instead, there will be a hypogammaglobulinemia. Albumin will be low, and there will be hypogammaglobulinemia. The area where there is should be gamma globulin is usually white. There will not be any staining in that. But here in this patient, we had a very small monoclonal band again, which can be possible. About 50% of the patients with light chain myeloma will give a very small band in the gamma region, and the other 50% will give hypogammaglobulinemia. Okay, the other one, yeah. This is the urine immunofixation. Now, in the previous separation, we confirmed the presence of a light chain myeloma, so we don't need to go straight for the urine immune fixation. Now, the urine immune fixation, you can see there is a lambda light chain superimposing with the Bence-Jones protein in the electrophoresis separation. In the ELP is your standard, that is your normal electrophoresis in your normal electrophoretic procedure that has applied to the urine sample. GAM is the antibodies applied for the heavy chains. If there is some sort of renal damage, or if there are heavy chain fragments in urine, there will be a band in the GAM range. But in light chain myeloma, you won't see a band in the GAM area. Now, kappa and lambda is for total, or kappa and lambda is for kappa and lambda chains, which could be fragmented ones. That is now here also we put antibodies. Can I go back to the slide, please? Can I go back to the slide, please? Hello? Yeah. Now here the lambda light chain one, you can see there is a band. This is where we have put the antibodies for the bound lambda chains. That is the antigenic epitopes on the outside of the light chain, right? So, and the LF kappa free and lambda free, where the F mark is for the antibodies prepared for the epitopes in the hidden area where the disulfide bonds are. If the if the bond is not there, if the light chain is free, that hidden epitope is exposed, and these antibodies will go and bind to those places. So this patient has both fragmented light chains as well as free light chains. So it's a light chain myeloma. And in the light chain, free light, this is a serum free light chain assay. In the serum free light chain, you can see very high lambda level, 16,655. Now, this has exceeded the normal linearity range of the assay. Even the analyzer did not show us that you need to dilute. I diluted because it is compatible with the previous history. Like in the patient's history, there has to be a light chain myeloma. So I put a 1 in 100 dilution and got this value. So this is actually a light chain multiple myeloma, and this is without much of renal damage, because if there is renal damage, there will be albuminuria in that patient, but there's no albuminuria in this patient, and kappa light chain also is kept within the normal range. So this is a light chain multiple myeloma. In these patients, you don't need to go for a serum immune fixation electrophoresis. Now, if you go for a serum immune fixation electrophoresis, you will see the light chain, even though you will see the kappa light chain, but here it's not necessary. Okay.
Thank you, madam. This is his bone marrow examination, which confirmed the infiltration by plasma cells. On the right-hand side downwards, you can see the immuno-IHC stain for CD138. So with the evidence of plasma cell infiltration in the bone marrow with elevated lambda light chain in serum and excretion of free light chains in the urine, along with the CRAB criteria, the diagnosis of symptomatic light chain myeloma was made, and he was treated with anti-myeloma treatment. VCD 6 cycles were given, to which he showed a dramatical response. His full blood count parameters and biochemical parameters became normal. Currently, his serum creatinine levels are 105 micromoles per liter. These are his latest serum light chain assays, which showed a normalization of kappa lambda ratio. And this is his latest urine protein electrophoresis report, which showed no abnormal bands. And that concludes my presentation. These are my references. Thank you. To carry on to present case number 3, I would like to invite Dr. Dasun Prasanni. She is a diploma trainee in clinical hematology attached to CNTH Ragama. Over to you, Dasun.
Can you see now?
Yes, of course.
I'm sorry. She found to have severe anemia and admitted to the hospital for further evaluation and blood transfusion ago, and not evaluated for the cause at that time. And she has no bleeding manifestations, and she is a non-vegetarian. She is a known patient for hypertension for last 2 years, and she is a retired teacher living with her husband, and she has a good family support and activity level ECOG 1, and she had mild impairment of bilateral hand functions only. On examination, she was severely pale, and cardiovascular examination, she had a mild systolic flow murmur. Respiratory and abdominal examination was unremarkable, and she had a bilateral small muscle weakness and wasting of the hands. This is the investigation summary of first admission. The full blood count revealed the severe anemia with HB of 4.4 grams per deciliter with normal white cells and platelet counts. Reticulocyte percentage was 2.1%, and the blood picture, she had normocytic normochromic red cells with subpopulation of round macrocytes, and there were polychromatic teardrops, acanthocytes, and occasional NRBC. And she had marker tubular formation. The white cells, normal total count with neutrophil predominance, and few plasmacytoid lymphocytes were seen. Platelets were normal. She had high ESR of 160 millimeters in first hour with elevated serum creatinine of 254 micromoles per liter. And the liver function shows normal transaminases and bilirubin levels with reverse albumin globulin ratio. And she also had elevated serum calcium levels of 3.4 millimoles per liter, and skeletal survey did not reveal any lytic lesions. This is the bone marrow aspirate, and bone marrow aspirate shows 62% of abnormal plasma cells, including plasmablasts, and many binucleated forms, occasional trinucleated and multinucleated forms. And there were plasma cells with many flame-shaped cytoplasm. The normal hematopoiesis was markedly suppressed. The trephine biopsy shows diffuse infiltration of abnormal plasma cells, accounting for the 70% of marrow cellularity, and the amyloid, the congruent stain did not reveal amyloid deposition. These are her serum protein electrophoresis reports. Rajita madam, can you please explain this?
Yeah. In these patients, there is a monoclonal. This is actually a capillary electrophoresis, right? There are two different types of electrophoresis. One is capillary electrophoresis, and other one is gel electrophoresis. Now, what the separations that you all have seen are all from capillary electrophoresis. Here, depending on the charge and the pH and those factors, first the proteins are separated, eluted, then only they make the separation which you have seen in the blue one. First blue separation, but in gel preparation, physically the proteins are separated first. So you see the blue stain separation first, and then out of that we make the densitometry scan on a clonal band in the beta region. Now here there is a very prominent immunoparesis. You can see the either side of the peak is almost touching the baseline. So there is a monoclonal band in the beta region with very prominent immunoparesis, which is basically a diagnostic of multiple myeloma. Then we have gone to the immune fixation part. Here in the immune fixation part, you can see two bands, YGG lambda. There is another small lambda band. You can see another small lambda band, which is correlating with another small band in the electrophoresis also, which we have not seen clearly in the immune fixation. In the immune fixation, the resolution is much better in the immune fixation. Sometimes small bands that you don't see in your normal electrophoresis separation, you will see in immune fixation. Now here you can see we have put only 3 antibodies, anti-IgG, anti-IgA, anti-IgM for heavy chains, and anti-kappa and anti-lambda for light chains. You all know there are 2 other types of multiple myelomas, E and D. But here we don't use this anti-E and anti-D antibodies to cut as a cost-cutting measure because those myelomas are quite rare. So we don't put this anti-E and anti-D, right? So we don't know with this L band alone, right? The L band alone is due to one of these E lambda or D lambda or just L band alone, right? So to find out whether this is L light chain myeloma or E or D light chain myeloma, we'll have to do a urine protein electrophoresis and a serum free light chain. That is the second step to detect whether this is a light chain myeloma or E and D heavy chain myeloma coming with this IgG lambda. Yeah. Now in the free light chain, this is again something similar to the previous one where we had to do a 1 in 100 dilution to get this 13,964. So this is another indication that lambda light chain is a light chain multiple myeloma. But here this urine Bence-Jones protein had become negative, which is the BJP method for the heat test. I think this is the heat test. Performances of this heat test is tricky. One thing is you have to maintain the temperature at 100 and you have to filter the urine sample keeping the temperature at 100, and you have to have the filter paper with the correct pore size. You can't use any filter paper. There is a specification for that filter paper. And you have to acidify you have to have acidified serial acidified samples also. So you have to maintain all these criteria to get a proper Bence-Jones protein Bence-Jones protein positive sample. So I think this is a false negative one. Normally now I don't do this BJP test. I go directly to the IFIX. It's urine immune fixation or urine protein electrophoresis, right? Now here, the second one, we have done a urine immune fixation electrophoresis. Now you all have seen from the history, this patient is having some sort of a renal insufficiency as well, okay? Now, because the patient's creatinine was high and the patient's EGFR was 19 or something, right? So in these patients, now since creatinine was high, that means this patient is having some sort of a tubular damage. So if we do a normal urine electrophoresis, this is an immune fixation, no? Just the normal urine immune fixation, urine electrophoresis, not fixation. Sometimes we will see albumin band and a monoclonal like band in the beta gamma region, which could be tubular proteinuria because this patient is having a tubular damage, or a monoclonal Bence-Jones protein. So in those patients, we will go straight to urine immune fixation to differentiate out whether the monoclonal band is a monoclonal band or a tubular proteinuria. If it is a monoclonal band, you will see either free lambda or free kappa bands in the plate. Now here in this plate, I can remember there is a very slight free lambda band also. But in the printout, we couldn't see that. But even though we have this lambda, the total 1 lambda fragments, right? We report this as the lambda light chain. So this patient is having a biclonal disease, heavy chain plus lambda light chain multiple myeloma.
Thank you, madam. So, her serum beta-2 microglobulin levels were elevated. It was 24.57 milligrams per liter, and she also had high uric acid levels. And these are the rest of the investigations we have done during the workup. And the nerve conduction study shows bilateral advanced carpal tunnel syndrome, and screening for peripheral neuropathy was negative. So, since patient had plasma cell infiltration in the bone marrow with evidence of monoclonal paraproteinemia and hypercalcemia, renal impairment, and anemia, the diagnosis of symptomatic multiple myeloma was made. And she belongs to ISS stage 3 because she had high serum beta-2 microglobulin levels. Though hemostasis was well achieved after the bone marrow biopsy, patient developed pain at right buttock following the day. Examination, there was mild bruising at the right buttock, but next day the pain worsened and she was unable to walk. The biopsy site was normal, but there was a large tender bruise over the right buttock, suggestive of an intramuscular hematoma due to delayed bleeding, and it was confirmed with the ultrasound scan. The urgent full blood count shows the hemoglobin level of 6.5 dropped from previous 8.5. And the coagulation screening shows initial coagulation screen. There was an isolated prolongation of APTT. She has no past history or any family history of bleeding manifestations. So as you can see, the APTT was prolonged 65.4 seconds, and it was corrected with normal plasma to 43.8 seconds. And the APTT came back to normal levels with 50 correction with prior. So in conclusion, these findings are compatible with the factor deficiency in the intrinsic factor pathway or a von Willebrand disease. And she has no evidence of inhibitors to coagulation factors. Since patient had monoclonal paraproteinemia with negative past history or any family history of bleeding, and acquired coagulopathy such as acquired von Willebrand disease is a strong possibility. So she was managed with transfusion of 2 units of red cell concentrates and FFP 10 ml per kg and cryoprecipitate 10 units on the first day. And then we have given cryoprecipitate for 5 days daily because her APTT came back to normal with cryoprecipitate until the pain and hematoma completely settled. And she was well hydrated and started on allopurinol, and she was prepared for anti-myeloma therapy. And initially we have given high dose dexamethasone for 4 days and then switched to VCD regime. Now patient is awaiting von Willebrand disease profile and specific factor assay in the intrinsic pathway. This is the investigations we have done during the follow-up visit after the completion of first VCD cycle. She had improved hand numbness and pain, and she was free of blood transfusions. Her hemoglobin level was 8.3 grams per deciliter, and her serum creatinine, albumin corrected calcium level, and the uric acid levels were again came back to normal levels, and the ATTT was reduced to 47 seconds from 64.4 seconds, though it's still elevated, but it has come down. This is her serum protein electrophoresis after completion of first cycle. The M band reduced to 18.9 grams per liter from 37 grams per liter. And immunofixation, now there is only single IgG lambda band. Initially she had IgG lambda band with another associated light chain band. Now after the completion of first cycle, the light chain band has disappeared. Now she has only a single band. And serum-free light chain assay shows a lambda light chain of 107 milligrams per liter, which was 13,000 previously. So in summary, my patient is 56-year-old female, diagnosed to have symptomatic myeloma, ISS stage 3 with biclonal gammopathy, prominent IgG lambda band and a second lambda band without an associated heavy chain. She developed right side buttock hematoma due to delayed bleeding. Investigation revealed evidence of factor myeloma-related acquired coagulopathy, most likely acquired von Willebrand disease. After the first cycle of chemotherapy, patient shows a partial response to treatment with normalization of serum creatinine, uric acid, albumin-corrected calcium, normal free light chain ratio, and a 58% fall in monoclonal band with an improvement of APTT. Currently, she is continuing VCD therapy and awaits bilateral carpal tunnel release surgery. These are my references. Thank you for listening. Our next presenter is Dr. Madhuwanti Jayavira, Senior Registrar in Clinical Hematology, attached to Faculty of Medicine, Ragama. Over to you, Dr. Madhuwanti.
Thank you, Dasun. I guess I am visible as well as audible. Before commencing the presentation, I would like to remind you all, if you have any questions, you can get them clarified by Dr. Rajita Samarasinghe, and there is a Q&A option. If you don't want to ask questions, you can type them in the box and send to us, and she will answer those after the presentations. So I'll be starting the presentation. This is case 4, another patient with anemia, high ESR, and paraproteinemia. Beginning with clinical presentation, this was a 74-year-old gentleman without significant comorbidity with a pre-morbid performance status of ECOG-2, presented to us with loss of weight, 5 kilogram loss over 3 months duration, and symptoms of anemia. He denied other B symptoms and history of recurrent infections or bleeding manifestations. On further inquiry, he did not have hyperviscosity symptoms, back or bone pain, symptoms of hypercalcemia, symptoms related to renal insufficiency. This history does not support tuberculosis or solid malignancy. Moving on to physical examination, the general examination was significant for PALO. There were no peripheral lymphadenopathy or mucocutaneous bleeding manifestations or dependent edema. Fundoscopy examination was normal. There were no evidence of hyperviscosity, including retinal hemorrhage or retinal vein dilatations. Abdominal examination was normal. There was no palpable hepatosplenomegaly. Neurological examination too was normal. There were no evidence of focal neurological deficits or evidence of peripheral neuropathy. Cardiovascular and respiratory system examinations also were normal. Moving on to diagnostic investigations, his complete blood count revealed hemoglobin of 8 grams per deciliter with normal white cell and platelet counts. Blood picture was significant for some macrocytic cells, teardrop cells, marked Rowley formation. His ESR was above 100 millimeter in first hour, and liver function test revealed reverse albumin globulin ratio with hypoalbuminemia. His creatinine clearance and total calcium level were normal. Further diagnostic investigations, from baseline investigations to specific investigations, serum protein electrophoresis revealed a sharp monoclonal band in the beta region with an M-band concentration of 48 grams per liter with immunophenotype of IgM kappa. Madam Rajita, would you like to comment on these reports?
Yeah, this is a plain and simple electrophoresis and immunotyping. As you said, there's a sharp band with a very prominent immunopharesis. You can see either side of the peak is almost touching the baseline. Albumin level is low and a monoclonal band is there with a very prominent immunopharesis and corresponding to IgM kappa. You can see the inhibition part. The M band is inhibited. There's no N band when you superimpose the separations, and the kappa also, there's no kappa band when you superimpose the inhibited sample with the previous original one. So this is immune inhibition.
Thank you.
Okay.
Thank you, madam.
It's a plain, this is a straightforward one.
Thank you, madam. Further investigations, his bone marrow aspirate revealed 16% of lymphocytes with plasmacytoid lymphocytes, and there were 12% of plasma cells scattered in clusters. His trephine biopsy was hypercellular with diffuse infiltrate of lymphoid cells, lymphoplasmacytic cells, and plasma cells accounting for 50% of marrow cellularity. Immunohistochemistry, the diffuse infiltrate was positive for CD138 as well as CD20. The CD138 positive cells were positive for CD20 also. Contrast enhanced CT chest, abdomen and pelvis revealed mild splenomegaly only. There were no intrathoracic or intra-abdominal lymphadenopathy. Therefore, the diagnosis was confirmed as Waldenstrom's macroglobulinemia. I put this picture in honor of late Dr. Jan Gustav Waldenstrom, who first described this condition. Moving on to staging investigations, his beta-2 microglobulin level was high, his albumin level was low, and his LDH was also elevated, and we could not get serum immunoglobulin level IgM done. Pre-treatment investigations, his viral serology, including hepatitis B, C, and retroviral were negative, and his cardiac functions were satisfactory. Moving on to risk assessment of Waldenstrom's macroglobulinemia. According to IPSS-WM prognostication criteria, he fulfills 3 risk factors out of 5. They are age more than 65, hemoglobin less than 11.5, and beta-2 microglobulin more than 3 mg per liter. So he belongs to stage 3 high risk category according to IPSS-WM prognostication criteria. Although not mentioned in IPSS-WM, elevated LDH and low albumin are also taken as risk factors, and our patient had both those high LDH and low albumin criteria. Indications for therapy. Not all Waldenstrom microglobulinemia patients are treated. There are certain clinical indications and laboratory indications to consider initiation of therapy. This patient had weight loss as well as low hemoglobin as indication for initiation of therapy. The treatment was based on ESMO clinical guidelines on management of Waldenstrom macroglobulinemia. According to ESMO, the treatment will be dependent on patient's fitness and the status of tumor burden. This patient was obviously belonging to unfit category. And as well as this patient did not have bulky lymphadenopathy or hepatosplenomegaly, and he did not have organ failure due to the disease. He had low hemoglobin as only the cytopenias. Therefore, he was in low tumor burden category. For the unfit low tumor burden patient category, there are several treatment options, including oral fludarabine, dexamethasone rituximab cyclophosphamide cycles, rituximab monotherapy, ibrutinib monotherapy, or chlorambucil monotherapy. The preferred treatment options for our patients are underlined in red color. They are 6 cycles of DRC, dexamethasone rituximab cyclophosphamide, or chlorambucil monotherapy 12 cycles. and the preferred option was DRC. But the patient was a bit hesitant to be started on cyclophosphamide. Therefore, we have started him on an alternative therapy, including chlorambucil, rituximab, prednisolone, 28-day cycles. Rituximab on day 1 and chlorambucil and prednisolone fixed doses for 14 days during the cycle with concurrent medications including acyclovir, fluconazole, calcium carbonate, cholecalciferol and alendronate. The response was monitored with monthly serum protein electrophoresis. The serum protein electrophoresis at the end of 5th cycle was 20 grams per liter. That means a 40% reduction from the baseline. According to the response assessment criteria, he has achieved a minor response only. However, currently patient is asymptomatic. He has no B symptoms. Instead, he has put on weight and his hemoglobin is well above 11 grams per deciliter. Therefore, the decision to whether to do a watchful waiting or starting on an alternative chemotherapy, particularly DRC, dexamethasone, rituximab, cyclophosphamide, is yet to be decided. This is my reference, ESMO clinical guidelines for Waldenström macroglobulinemia management. And thank you all for listening to my presentation. Now I would invite Dr. Rajitha Samarasinghe to elaborate on further investigations of paraproteinemia. Over to you, madam.
Thank you. Thank you. Now, first I will start with the basic serum protein electrophoresis. Now, you all have seen there are two methods of doing it in Sri Lanka at the moment and in the world. One is capillary electrophoresis, one is gel electrophoresis. Capillary electrophoresis has its own advantages because capillary electrophoresis is much quicker and you can run you can run large number of samples in one go and it can be automated. But gel electrophoresis is semi-automated. It's not a fully automated thing, it's a semi-automated thing. And number of samples that you can run is limited, like maximum is 6 samples per run. But my own experience is for multiple myeloma, for the detection of monoclonal band, gel electrophoresis is much better. Because the bands are, the resolution is much better, the bands are separated much better, and you don't see unnecessary bands in gel electrophoresis. And the other thing that you have to keep in mind is in both these types, the presence of biclonal bands. Now, when you see two clones of monoclonal bands in electrophoresis, this could be either a biclonal disease or could be due to band polymerization, right? Now, band polymerization also can give rise to an additional band, which is not a monoclonal band. Here you have to do either, you have to treat the sample with beta-mercaptonuria, which is not available in Sri Lanka at the moment. But if you do an immune fixation in that same sample, if it is due to a band polymerization, you will not see that band in the immune fixation. So we are doing immune fixation in those biclonal separations in serum protein electrophoresis, right? Now going next to immune fixation electrophoresis, serum immune fixation electrophoresis. The indication of serum immune fixation electrophoresis is one, the biclonal production. Other one, if there is a band in the alpha 1 or alpha 2 region. Now we all know if there are bands in the alpha 1 or alpha 2 regions, this could be due to acute inflammatory responses or could be due to a renal pathology or can be due to a IgA myeloma as well. So in any of these cases, when you want to confirm the diagnosis of multiple myeloma, you can go for a immune fixation electrophoresis. The second one is the one that we have in case number 2 or 3, where there is a polyclonal one, but you are not sure whether there is a hidden monoclonal band also. So in those cases, again, you can go for a immune fixation. Right? And the third one is for the band identification. Now in Waldenström, it's IgM. So if you want to identify the band, you can go for an immune fixation. But keep in mind, immune fixation, I have told you, we have using antibodies and those antibodies are very expensive. So it's a costly procedure. So for each and every multiple myeloma, if the band identification is not beneficial for treatment, please do not go for a typing the band identification by requesting immune fixation, because these procedures are very, very expensive, right? And the third one is urine immune fixation. Again, the indication for urine immune fixation is to confirm the presence of a Bench-Jones proteins. If you can do a urine protein electrophoresis, just a plain old urine protein electrophoresis, and the patient's renal functions are normal, a plain old urine electrophoresis without involving antibodies can be done, and you can see your monoclonal band there. But if the patient is having a renal failure or a tubular dysfunction, where you expect the patient to excrete tubular proteins, and these tubular proteins we can confuse these tubular proteins with Bench-Jones proteins. Then you can do a fixation by involving antibodies to find out whether this band is a monoclonal band or not, Bench-Jones protein band or not. Then serum free light chain assays, we can do this. We used to do this in urine as well, but nowadays we don't use urine as free light chain, because these light chain myeloma patients, you all know, light chains are filtered and reabsorbed by renal tubules. But when the load is very high, the tubules can't handle those. So these light chains are excreted. That is how we see urine light chains. But when the load is very high, these light chains get precipitated and they block the tubules and damage the tubules. So ultimately, at one point, the kidneys will not excrete light chains from urine. Then you will not see urine light chains, but the patient is very bad. So if you depend only on urine free light chains, at one point you will think that the patient has recovered, but no, patient has worsened. So it's always good to do serum free light chain and avoid doing urine free light chain. And the other one is in chronic renal failure and chronic inflammation, there will be in chronic inflammation, there's a polyclonal increase in immunoglobulin. So you will see both kappa and lambda chains increase, but maintaining the ratio in the normal range. So when you are assessing a patient using serum free light chains, if the patient is having a chronic inflammatory condition, you have to be very careful when interpreting. And the other one is if the patient is having a chronic renal failure. Again, I told you, renal tubules do a major role in excreting light chains. So if the patient is having a chronic renal failure, again, your interpretation could be difficult. So I think the international working groups are they are in the point of making a new reference range for patients with chronic renal failure for serum free light chain assays, the ratios and the light chain levels. But till then, we'll have to keep in mind that if the patient's renal functions are not good, the interpretation is a little bit tricky of the serum free light chain assays. But you can use this serum free light chain assays for the long-term follow-up of patients with multiple myeloma. Okay. Is there any questions? Any questions?
If no questions are there, madam, yeah.
Yeah. Thank you very much. Thank you for inviting me for this. I hope this had been informative for the trainees actually. Thank you.
Thank you, Madam Rajita Samarasinghe, for giving, spending with us and sharing her valuable experience with us. Now, this makes the end of the phase 1 of the Red Box February 2021. Before handing over to the next proceedings, I must thank Professor Senani Williams, Dr. Jacinta Costa, and Dr. Tanuja Disanayake, who were continuously guiding us on this those presentations. Now I would hand over to Dr. Pabasara Munisinghe, Senior Registrar in Clinical Hematology at NHSL, to continue with the rest of the red box. Over to you, Pabasara.
Drop them into the Q&A box. The first presentation first presentation is somewhat related to the previous presentations. Dr. Vasanthi Wickramasinghe, Senior Registrar at Faculty of Medicine, Colombo, Dr. Vijini Ranasinghe and Dr. Santhan Sivakumaran, Diploma trainees at Faculty of Medicine, Colombo, will talk about paraproteinemias, different strokes in different forms. Over to you, Dr. Vijini.
Regarding a patient who has presented with renal failure and found to have paraproteinemia. This is Mrs. S, 53-year-old housewife, mother of 2 children from Ingiriya, with background medical history of bronchial asthma and dyslipidemia. She has presented to us with progressively worsening generalized body swelling for 3 months, and she complained of frothy urine, but her urine output was normal. No symptoms suggestive of chronic liver cell disease, congestive cardiac failure, malabsorption, or hypothyroidism. No past history of diabetes, hypertension, recurrent urinary tract infections, no B symptoms or symptoms suggestive of autoimmune diseases. She was detected to have high blood pressure on admission. There was no alternation in her consciousness, no other uremic symptoms, no evidence of thrombosis. On examination, she was pale, there was generalized edema, her blood pressure was 150/100, and respiratory examination, percussion note dull in bilateral lower zones, and air entry also reduced in bilateral lower zones with bibasal crepitations. There was no organomegaly, but free fluid was present. In summary, this is a 53-year-old female patient presented with progressively worsening generalized body swelling, frothy urine for 3 months duration, and found to have fallow, generalized edema, high blood pressure on examination. From the history and examination, we excluded chronic liver cell disease, congestive cardiac failure, malabsorption, or hypothyroidism. So renal pathology is most likely either nephrotic syndrome or nephritic syndrome. Keep that in mind. We did our investigation and found to have moderate hypochromic microcytic anemia with low normal platelet count. And blood picture shows mild ruler formation. The UFR reveals microscopic hematuria with heavy proteinuria. Serum creatinine was high, with corresponding eGFR was very low, and UPCR was more than nephrotic range. An ultrasound scan abdomen shows increase. So the medical team has done renal biopsy and it showed an acute diffuse proliferative glomerulonephritis, and many glomeruli show as positive and congruent negative nodules, morphologically suspicious for light chain disease. The glomerulonephritis may possibly be developing in a background of light chain deposition disease. And supporting the glomerulonephritis, there were 40% dysmorphic RBC. Then the immunofluorescence of the renal biopsy report came as strong globular staining for IgG and moderate granular staining for C3, but there was no staining for IgA, IgM, light chain kappa, and lambda. Meantime, the immunohistochemistry of the renal biopsy report came as glomerular stain negative for both kappa and lambda. So the nodular deposits are more likely to be heavy chains. At the same time of the renal biopsy, we did serum protein electrophoresis also. It revealed abnormal monoclonal band of 10 gram per liter in the gamma region, but her urine protein electrophoresis was normal. Serum protein immunofixation and abnormal monoclonal band consisting of IgG and lambda chains were present. Her serum free kappa lambda ratio was 0.21. After that, we did bone marrow biopsy. It was hypercellular marrow with 10% plasma cells, and when we put immunohistochemistry CD138, positive cells were 10 to 15%. There were no depletions in her skeletal survey. Her serum calcium level was normal. There was a reversal of albumin globulin ratio. And we made the diagnosis of multiple myeloma with heavy chain deposition in kidney. For prognosis, her beta-2 microglobulin level was high, her albumin was low, serum LDH was high, and we didn't do the cytogenetics because the patient couldn't afford. So the complete diagnosis of multiple myeloma, ISS stage 3 or RISS stage 3 was made. Next, the management part will be discussed by Dr. Sanathan. Thank you.
Thank you, Dr. Vijini. I am going to discuss about the management of previously discussed patient. In summary, 53-year-old patient with bronchial asthma and dyslipidemia presented with generalized body swelling and frothy urine for 3-month duration. On examination, she was pale and generalized edema and detected to have high blood pressure. Other than that, systemic examination was unremarkable. Her urine UFR shows nephrotic range proteinuria with high serum creatinine of 2.3 milligram per deciliter, and ultrasound abdomen shows acute kidney injury. Renal biopsy confirmed the acute diffuse proliferative glomerulonephritis, and the renal biopsy IHC shows negative for both kappa and lambda, and immunofluorescence IgG is strongly positive with 3+ and moderate 2+ positive of C3 and negative of kappa lambda. So the diagnosis was made heavy chain deposition disease of kidney with acute kidney injury. The serum protein electrophoresis M band of 10 gram per liter with the IFIX of IgG lambda with abnormal serum free light chain ratio of 0.21 with a high lambda free lambda of 386, and UP was normal. The bone marrow examination, hypercellular marrow with 10% plasma cells with IHC confirmed with CD138 10 to 15%. The criteria high creatine and low hemoglobin, and confirms the diagnosis of symptomatic multiple myeloma. For the staging, multiple myeloma ISS stage 3. This is the timeline for the presentation. Initially, patient presented with generalized edema and proteinuria from July 2019. Then patient, after presenting of symptoms for 3 months only, the patient came to the medical attention. Initially, patient present to the local hospital. Ultimately, patient came to the NHSL by January 2020. At that time, renal biopsy and immunofluorescence was done, and followed by February and March 2020, serum protein electrophoresis, IFIX, serum free light chain assay, and UP were done, and followed by bone marrow biopsy done. Unfortunately, following a COVID pandemic, patient defaulted clinic follow-up, and again patient presented to NHSL by June 2020. At that time, bone marrow IHC came, and it confirms the multiple myeloma with heavy chain deposition disease. And ultimately, after presentation, there is a much delay, roughly around 1 year for the diagnosis. Then by July 2020, pre-treatment evaluation done, and by the August 2020, treatment was started. How we manage the patient: initially break the bad news to the patient and the family, patient education, pre-treatment investigation, management of acute problems, specific treatment, supportive treatment, management of complication, and response assessment. The pre-treatment investigation, we did 2D echo, that was normal, and viral screening, hepatitis B surface antigen and hepatitis C antibody, all were normal. Nerve conduction study was done before starting bortezomib and thalidomide treatment. Those are prone to cause nerve conduction problem. So nerve conduction study was normal. Dental referral done before starting a bisphosphonate, that was normal. LFT normal other than reverse albumin globulin ratio. Fasting blood sugar, impaired fasting blood sugar of 116 milligram per deciliter. Thyroid function test was normal. These are the acute problems we encountered. Renal impairment with a serum creatinine of 2.3. We managed with good hydration. And the anemia of 7.8, we didn't transfuse red cell since the patient was asymptomatic. And erythropoietin also delayed due to high blood pressure. And bisphosphonate also delayed due to renal impairment. The specific treatment, we initially referred the patient to Apeksha Cancer Hospital to assess the suitability of autologous stem cell transplantation, and patient was registered for autologous stem cell transplantation registry. The specific treatment, we start bortezomib-based triple regime with a VTD 28-day cycle with IV bortezomib, thalidomide, and dexamethasone, along with allopurinol, acyclovir, omeprazole, and aspirin were given. And IV zoledronic acid 3 milligram after completion of VTD cycle 5, because initially she had a high serum creatinine. The management of complication, the patient had anemia and found to have iron deficiency with iron saturation of 8.9. And we start iron supplement, oral iron supplement. We didn't transfuse blood. And followed by we started subcut erythropoietin 4,000 intentional unit 2 weekly with a strict blood pressure monitoring. Following a treatment, we monitor the patient. Full blood count, serum creatinine were monitored weekly before each dose of bortezomib. And liver function test, serum calcium, and random blood sugar were monitored before each cycles. Following a 4th cycle, patient's serum creatinine came to normal level. This is the response assessment. The initial serum protein electrophoresis, M-band of 10 gram per liter with iron-free light chain ratio of 0.21 with high free lambda of 386. Following a first cycle, serum protein electrophoresis M-band came to 4 grams per liter. At that time, patient achieved a partial response. Following a second cycle, serum protein electrophoresis, no abnormal monoclonal band. We take it as a very good partial response. And following a third cycle, serum IFIX also, there is no band. So the patient achieved the complete remission following 3rd and 4th cycle. The 5th cycle reports are awaiting. So we plan to continue VTD 6 cycle and send for autologous stem cell transplantation followed by lenalidomide maintenance for at least 2 years. And long-term plan is monitor for relapse clinically and biochemically and manage accordingly. Thank you. I will hand over to Dr. Vasanthi Wickramasinghe, Senior Registrar, Clinical Hematology, Faculty of Medicine. Over to you, Dr. Vasanthi.
And good morning. So I would be doing a brief presentation on paraprotein-related kidney disease. As we all know, paraproteins are monoclonal immunoglobulin fragments or intact immunoglobulins, which are produced by a clonal proliferation of B cells or plasma cells. They can be detected in blood and urine. Paraproteins are identified as a culprit for multi-system disorders, and they mainly target the nervous system, the kidneys, and the skin. Paraprotein-related kidney disease is very important, and the group International Kidney and Monoclonal Gammopathy Research Group was formed in the year 2009 with the mission of improving the understanding treatment strategies of the kidney disease caused by monoclonal proteins. So what is this paraprotein-related kidney disease? It's a complex group of diseases caused by an abnormal paraprotein secreted by a clone of B cells or plasma cells. They can have direct effects or indirect effects, causing renal injury, and can cause kidney disease irrespective of the concentration of the paraprotein or the tumor burden. They can be associated with overt plasma cell disorders or B cell disorders like multiple myeloma and B non-Hodgkin's lymphomas like Waldenstrom's macroglobulinemia, or else could be associated with monoclonal gammopathy with renal involvement only. So what is monoclonal gammopathy of renal significance? The topic monoclonal MGRS was initially described by the International Kidney and Monoclonal Gammopathy Research Group in the year 2012. It's a group of disorders in which monoclonal immunoglobulins secreted by a non-malignant or pre-malignant B cell or plasma cell clone causes renal damage. Over the years, there's a lot of understanding and interest on this topic, and the updated 2019 definition of MGRS is any plasma cell or B lymphocyte clonal proliferation with both one or more kidney lesions that are related to the produced monoclonal immunoglobulin, and the underlying plasma cell or B cell clone doesn't cause tumor complications or meet any current hematological criteria for specific therapy. The diagnosis of this disease entity is quite challenging, mainly because there is a wide range of disease manifestations which are not specific. And also there is difficulty in detecting the pathogenic clone because of the small size of the malignant clone and the small amount of paraprotein produced. And also, an incidental finding of a paraprotein is quite common in the elderly population. About 3% of the people more than 50 years and up to 8% of the people more than 80 years can have an incidental finding of a paraprotein. Further, renal disease is also quite common in the elderly. Therefore, a patient can have renal disease and IMGAS that are completely unrelated. On the other hand, untreated paraprotein-associated renal disease has a high risk of developing into end-stage renal disease, has high rate of recurrence in transplant recipients, and can lead to rapid graft loss. Therefore, close cooperation between the nephrologists and hematologists should be there to determine whether renal impairment is caused by paraproteins. So what is the pathogenesis of this disease entity? As we all know, under normal conditions, the immunoglobulins are produced by plasma cells, and there is a greater production of light chains than heavy chains. The light chains are freely filtered by the glomerulus, and they are uptaken by the proximal tubule by clathrin-dependent endocytosis and catabolized there. Only a small amount of free light chains appear in urine. However, the intact immunoglobulins are not filtered by the glomerulus because of their large size. When there is an excess of paraproteins due to a clonal proliferation, there would be excess of both intact monoclonal globulins and light chains. The exact mechanism of injury by intact monoclonal immunoglobulins is incompletely understood. However, it's thought that they interact with the glomerular cells and cause diseases, as well as they can precipitate in the capillaries and arteriolar lumina. The excess of free light chains in the proximal tubule overwhelm the proximal tubule's catabolic capacity. Therefore, large amounts of light chains remain within the tubular fluid, and they can trigger apoptotic pathways and induced pro-inflammatory cytokines, giving rise to inflammatory cell infiltration, fibrosis, mesenchymal transformation of tubule epithelial cells, and cell death, ultimately resulting in light chain proximal tubulopathy. In the distal tubule, the light chains can cause cus nephropathy, where the monoclonal light chains have a strong affinity for uromodulin or TAM-host proteins produced by the loop of Henle, which form insoluble cus in the distal tubule. They cause intrarenal obstruction, rupture, and tubulointerstitial inflammation, causing obstruction of the nephron and reduction in the glomerular filtrate, tubular atrophy proximal to the obstruction, ultimately causing either acute kidney injury or chronic kidney disease. So these diagrams also show the same pathogenesis I discussed earlier. And the mechanisms of renal injury in paraprotein-associated kidney disease could be due to direct injury, that is deposits in the glomeruli, tubulointerstitial space, and intrarenal vascular deposition, or it could be indirect injury. In multiple myeloma also, the renal disease could be either paraprotein dependent or independent. I'm sure you all know these causes. So what are the clinical features of this condition? Well, there's a spectrum of clinical features widely varying according to the affected portion of the kidney. Most of the patients are more than 50 years. When there is glomerular disorders, usually they have proteinuria, hematuria, chronic deterioration of renal function, systemic hypertension. The tubular disorders can present with tubular proteinuria, proximal tubular dysfunction, acute kidney injury, and progressive CKD. How do we diagnose paraprotein-related kidney disease? Well, it needs a high degree of clinical suspicion. Renal biopsy along with detailed hematological workup is essential in patients with unexplained urinary abnormalities with or without renal impairment. The paraprotein screen should importantly include both serum and urine studies and also can be supplemented by serum-free light chain assays to increase the diagnostic sensitivity. Renal biopsy is the gold standard of diagnosis, and it requires the integration of both morphological and immunological features, including immunohistochemistry and immunofluorescence. Electron microscopy is also preferred for detailed ultrastructural abuse. The renal histopathology has a wide spectrum of lesions, and all compartments of the kidney can be involved. There could be monoclonal deposits, which are non-organized or organized, and the organized ones could be fibrillar, microtubular, inclusion, crystalline deposits. This diagram also demonstrates the various microscopic and immunofluorescence images of the histopathological features. However, I think it's a little too much for us to digest. What we should know is that there could be a wide spectrum of biopsy features and immunofluorescence features in this disease entity. So when a patient has undergone a kidney biopsy and there is immunoglobulin or light chain restriction on immunofluorescence, then the serum and urine monoclonal studies should be carried out, followed by bone marrow biopsy, plus or minus a lymph node biopsy. A C3 predominant deposit also warrants investigations in view of excluding paraprotein-related renal disease. Now we'll move on to the management of these patients. It requires close communication between the pathologists, nephrologists, and the hematologists. And the effective treatment should involve both specific and supportive care. Treatment is indicated to preserve or restore kidney function as well as to prevent recurrence after kidney transplantation. The general management includes prompt treatment of suspected infections, management of salt and water balance, management of hypercalcemia, and preservation and replacement of organ function. The goal of therapy of specific management is to eliminate the underlying clone while preserving the kidney function. The choice depends on the nature of the underlying clone and the degree of renal and other organ involvement and the availability of therapeutic agents. The renal response usually correlates strongly with the hematological response. Therefore, the hematological response is assessed by measuring paraprotein concentration and free light chain assays. For improved outcome, a rapid suppression of paraprotein secretion with chemotherapy is needed. In studies done on survival on myeloma patients with renal failure, it has been shown that newly diagnosed patients with renal failure versus without renal failure, the patients with renal failure have a lower survival rate. And also in patients treated with renal failure, when they recover their renal functions after treatment, they have a higher survival than patients with irreversible kidney injury. And interestingly, in patients without renal involvement, when compared with the patients with recovered renal function after treatment, the survival is almost similar. So that signifies the importance of prompt diagnosis and management of these patients to prevent the progression of kidney disease. So in summary, patients with unexplained proteinuria and renal dysfunction should be screened for paraproteins. The monoclonal gammopathy can produce renal disease irrespective of the concentration of the paraprotein. Paraprotein-related renal disease has a wide spectrum of non-specific clinical features, and unrelated MGUS and renal impairment can be present in elderly patients, and untreated paraprotein-associated kidney disease leads to end-stage renal disease and rapid loss of graft function. Therefore, prompt commencement of chemotherapy is crucial to prevent progression of renal impairment. Even in the patient discussed earlier, there was a delay of about 1 year from her initial presentation for various reasons. Luckily, her renal functions improved with treatment. However, it might not be the case in every patient, and they might have progressive renal disease, which might even cost their lives. Therefore, the key message we want to convey from this presentation is that as hematologists, we should be aware about this disease entity, and there should be a close collaboration between nephrologists and us in order to diagnose these patients promptly and provide optimal care to them.
Thank you, Dr. Vasanthi, for the excellent presentation. Let's move on to the second presentation. Dr. Ruwantika Senaratna, Diploma Trainee at Late Ridgeway Hospital, Colombo, and Dr. Ashani Veeratunga, Diploma Trainee at National Hospital of Sri Lanka, will discuss about hypercoagulable states in thalassemia. Over to you, Dr. Ruwantika.
Then he has taken treatment from private sector several times, but his pain was progressively increased in severity and it was persisting even at rest. He was incapable of doing activities of daily living and started tour walking. Then they got admitted to TH Anuradhapura in September. Their CT angiogram done and found to have extensive arterial thrombosis in the left lower limb. Their femoral artery thrombectomy done, but his pain was persisting and left side toes started to darken in color. The thalassemia intermedia was diagnosed at the age of 6 years. Regular transfusion started after 1.5 years from the diagnosis, initially 3 monthly, then frequency increased to 2 monthly. So far, 13 blood transfusions done. Currently, he doesn't have symptoms of anemia or heart failure. On examination, his growth examination showed there's growth retardation, there's mild pallor, maxillary prominence, and mild skull bossing was there. And lower limb examination, all 5 toes in the left side lower limb were gangrened, and there's a wound over the dorsum of the foot, and foot was called to touch. In the left side, only the femoral pulse was present. Popliteal, posterior tibial, and dorsalis pedis pulses were absent. CVS RS examination were normal. Abdominal examination, there's mild hepatosplenomegaly, no palpable masses. Moving into investigations, his full blood count shows HB 8.9 with MCV 64.5. His blood picture showed hypochromic microcytic red cells, target cells, anisopoikilocytosis, partially hemoglobinized cells, irregularly contracted cells, teardrop cells, basophilic stippling, polychromatic cells, and few erythroblasts. As there were no records about the type of hemoglobinopathy, we did hemoglobin electrophoresis and it showed HbA 38.6, HbF 51.4. There's a 6% band in the HbD zone and HbA2 4%. HbLC of the patient showed HbA 32.4, HbA2 11.2, HbF 47.9. So the diagnosis made that the patient is compound heterozygous beta thalassemia hemoglobin leprosy with a clinical picture of thalassemia intermedia. His father's hemoglobin electrophoresis showed 10.2% band in the HbD zone, and HbLC showed HbA 77.5, HbA2 10.9, HbF 1.2. So the father is diagnosed with heterozygous hemoglobin leprosy or HB leprosy trait. Mother's HbLC done and conclusion was beta thalassemia trait. The CT angiogram of the left lower limb showed there's arterial thrombosis from the level of adductor hiatus in left saphenofemoral artery, popliteal, and posterior tibial arteries with extensive collateral supply with partial recanalization. Then we did sickling, Ham's test, DRVVT, KCT. Those were negative. His lipid profile also normal. And protein CS, antithrombin 3 levels, and genetic studies were pending. So moving on to the management, vascular team initially did left femoral artery thrombectomy with exploration of the left popliteal artery, but it failed. After that, child developed toe gangrene. In this child, bypass surgery is not possible because there's complete arterial occlusion below the left knee level, causing absent runoff flow. Then we gave a trial of prostaglandin to develop collaterals, but during the third cycle, this child developed a reaction. Therefore, we have to stop that. Now, waiting for DSA studies to assess the arterial supply and collateral supply. Anyway, the vascular opinion is to wait for auto-amputation of the limb, as further interventions may cause more complications, which could lead to amputation at a higher level. And we are doing symptomatic management like daily dressing of the wound, physiotherapy, and adequate pain management. Hematological management, top-up blood transfusions to keep the hemoglobin level more than 9 grams per deciliter, and we are giving folic acid. We started aspirin and anticoagulant with warfarin. Also, we started on hydroxyurea to reduce the hypercoagulable state. To discuss further, I would like to invite Dr. Ashan.
Thank you, Dr. Nuantika. Good morning. I'm going to briefly discuss regarding coagulopathies in thalassemia. As we know, despite the difficulties in treatment, standards of care for thalassemia patients have improved over the time and their life expectancy is increased. So we are encountering more and more additional complications in our practice, such as chronic hypercoagulable state leading to clinical thrombosis has been identified in thalassemic patients, particularly in beta thalassemia major, beta thalassemia intermediate, and alpha thalassemia patients. It's most commonly seen in beta thalassemia intermediate patients and mostly patients aged above 35 years, and rarely it can present in children also. As our patient is compound heterozygous for beta thalassemia and hemoglobin leporate and having clinical picture of thalassemia intermedia, I will briefly discuss regarding hemoglobin leporate first. Regarding the mechanism of formation, there's unequal crossover during meiosis in chromosome 11, leading to formation of delta beta fusion gene. It encodes for variant delta beta fusion chain, which is synthesized at reduced rate, forming variant hemoglobin leporate. There are three structurally different types of leporate hemoglobin differing in crossing over region. Hemoglobin leporate Boston or Washington, it's the most common type and mainly seen in Mediterranean region. Hemoglobin leporate Baltimore and hemoglobin leporate Hollandia. These are the genotypes of hemoglobin leporate. Hemoglobin leporate trait, hemoglobin leporate homozygotes who are having clinical picture of thalassemia major or intermediate, and compound heterozygotes for hemoglobin leporate and beta thalassemia. They also have clinical picture of thalassemia major or intermediate. Regarding laboratory features, blood film findings are similar to beta thalassemia trait or intermediate with hyperchromic microcytic red cells. In hemoglobin electrophoresis, hemoglobin leporate has the same homogeneity as hemoglobin S, D, and G on cellular associated electrophoresis at alkaline pH, but it moves with hemoglobin A at acid pH. So to further differentiate, we can go for hemoglobin HPLC. In HPLC, hemoglobin E, hemoglobin leporate coeludes with HbA2. So we can assess the HbA2 peak. If it is 7.5% to 15%, it is suggestive of hemoglobin leporate. If it is 20 to 25%, it is suggestive of HbE. Then hemoglobin electrophoresis findings in different genotypes. Hemoglobin leporate trait will show 5 to 15% of hemoglobin leporate, reduce HbA2 and increase hemoglobin F. Hemoglobin leporate homozygotes will show hemoglobin F and leporate only. Compound heterozygotes for hemoglobin leporate and beta thalassemia will show hemoglobin F, leporate, A2 with or without some hemoglobin A. So moving back to our topic, thrombosis in thalassemia. Among thalassemics, following subgroups of patients are at higher risk of thrombosis. and cerebrovascular accidents. Those are beta thalassemia intermediate patients, females, splenectomized patients, never or previously minimally transfused patients, patients with platelet count equal or more than 500 into 10 to the power 9 per liter, patients with nucleated red blood cell count equal or more than 300 into 10 to the power 6 per liter, hemoglobin less than 9 grams per deciliter, age about 20 years, family history of thromboembolic events, previous thromboembolic events, patients with iron overload, pregnant patients, and patients with other conventional risk factors for thrombosis. A positive transfusion history and hemoglobin level equal or more than 9 grams per deciliter found to be protective against thrombosis. So these are the evidence and findings from studies. 1.65% of the thalassemia population had thromboembolic events, and it is 4.38 times more frequently seen in thalassemia intermedia than thalassemia major. And venous events are more common than arterial events. It's the fifth most common complication in thalassemics, and venous events are more commonly seen in thalassemia intermedia, and arterial events are more common in thalassemia major patients. So what are the thromboembolic manifestations in thalassemia patients? They can present with cerebral thrombosis, they can have overt stroke, and asymptomatic brain damage also found to have more frequent in this population than general population. It can be detected by ischemic lesions in MRI, arterial stenosis in MRI, and decreased neuronal function in PET-CT. They also can have spontaneous deep vein thrombosis. Pulmonary thromboembolism also found to have more frequent in this population. It's mainly seen in beta thalassemia intermedia patients, and asymptomatic pulmonary vascular disease is more frequent. It can be detected by investigations like 2D echo showing pulmonary hypertension and right heart failure, and altered lung function test and autopsy findings showing thrombosis in pulmonary arteries and microvasculature. They also can have recurrent arterial occlusions. So, what are the possible contributory factors for this hypercoagulable state leading to clinical thrombosis in thalassemia patients suggested by studies? They have three major abnormalities: platelet abnormalities, pathological RBCs, and endothelial injury and activation. Other minor contributory factors are iron overload state, splenectomy, reduced level of antithrombin 3, protein C, protein S, and increased atherosclerosis. This image summarizes the possible hemostatic changes in thalassemia. They have pathological RBCs with phosphatidylserine exposure on outer leaflet with increased thrombin generation, and these RBCs are rigid, deformable, and more prone to aggregate. They have endothelial injury with expression of adhesion molecules and tissue cells. And they have platelet abnormalities like thrombocytosis, chronic activation, and increased adhesion and aggregation. These major factors leads to increased thrombosis in these patients, and it is facilitated by reduced level of antithrombin 3, protein C, protein S, and iron overload state will facilitated by causing endothelial injury, endocrine and hepatic dysfunction, and increased atherosclerosis. Splenectomized patient will have increased number of these pathological RBCs and thrombocytosis. Transfusion history will reduce the number of pathological RBCs and have negative effect on thrombosis. So further elaboration on platelet abnormalities, they have chronically activated platelets with enhanced platelet adhesion and aggregation. This is confirmed by studies found that 4 to 10 times more higher metabolites of prostacyclin and thromboxane A2 in this population due to enhanced production of thromboxane A2, and flow cytometric studies also suggested increased fraction of platelet carrying the activation markers like CD62P and CD63. This platelet activation status persists from early childhood even when clinical thromboembolic events were rare. So this is the role of pathological RBCs in this hypercoagulable state. As we know, in thalassemia, there's partial or complete deficiency of alpha or beta globin chain synthesis. So remaining globin chain will undergo degradation and denaturation with heme disintegration and release of toxic free iron, which leads to formation of reactive oxygen species. This oxygen species will cause oxidative membrane damage and oxidative modification, particularly in membrane band 3 protein and spectrin. This will in turn leads to activation and assembly of prothrombinase complex, ultimately leads to increased thrombin generation. This process also associated with translocation of negatively charged phosphatidyl serine into outer leaflet of red blood cells, leading to increased thrombin generation. So, this increased thrombin generation will lead to increased thrombus formation, increased platelet activation, increased endothelial activation with expression of tissue factor and leads to thrombus formation, and activation of granulocytes and monocytes leads to endothelial activation and thrombus formation. They were found to have low levels of antithrombin 3, protein C, and protein S, which is acquired at an early age. In iron overload states, non-transferrin bound iron will cause oxidative vessel injury with lipid peroxidation and formation of atherosclerotic plaques, further facilitating thrombosis. And interestingly, inherited thrombophilia does not show the role in hypocoagulable state in these patients. These markers of platelet and coagulation activation are persistently elevated in adults and children alike, even in the absence of overt thromboembolic events, suggesting that this is largely a subclinical process. So, moving to the management of this hypocoagulable state leading to clinical thrombosis, as this is a chronic underlying process, long-term preventive strategies should be taken. Once established, no effective treatment and little can be done and damage could not be reversed. So, treating clinicians should be aware of this uncommon complication and taking long-term preventive strategies is utmost important in these patients. So, what are the strategies of primary prevention? Blood transfusion to maintain hemoglobin more than 9 grams per deciliter. It will improve ineffective erythropoiesis and decrease the level of pathological red blood cells with thrombogenic potential. This explains the clinical observation that these thromboembolic events were regularly transfused beta thalassemia major patients than beta thalassemia intermediate patients. And hydroxyurea therapy will reduce the phospholipid expression on red blood cells and reduce the WBC count. Prophylactic antithrombotic therapy is suggested for high-risk patients with beta thalassemia intermedia who are exposed to transient thrombotic risk factors like surgery, immobilization, and pregnancy. Aspirin therapy is suggested for splenectomized patient and patients with platelet count more than 500 into 10 to the power 9 per liter. There are no sufficient evidence to suggest iron chelation in this patient for primary or secondary prevention, but when it is used for a different indication, beneficial effect may be observed. So, what's the management of established thrombosis? As I told, after establishing the thrombosis, little can be done, but we can start anticoagulation therapy to reduce further propagation. Then vascular surgical interventions can be considered like bypass grafting, thrombectomy, and prolonged antithrombotic therapy is suggested for thalassemia major patients with thrombosis, as for any patient with thrombophilia. So this is the end of my presentation. These are my references. Thank you for listening.
Thank you, Dr. Ashani, for the interesting presentation. Now I would like to invite Dr. Vishaka Ratnamalala, consultant hematologist at National Hospital of Sri Lanka, to talk about management of hemophilia, practical aspects. Over to you, madam.
Thank you. Yeah, so thank you for giving me this opportunity. I'll talk about practical aspects of hemophilia because there are a lot of problems we see. So first thing is, according to the WFH recommendation, 5 essential components of an accurate diagnosis. This is simple things, but we do a lot of mistakes. First, we must select the correct patient for investigating for the hemophilia or any factor deficiency. That depend on the history. If the patient has tooth extraction and mild bleeding to after the extraction, but if she is having normal menstruation, she may not be a candidate for factor correction study. So like that, we have to look at the history and decide. Then utilize in the appropriate laboratory staff. We should have a trained staff rather than having trainees or on roster basis, which will create problems for coagulation tests. And we have to select the right test by considering the history and examination properly. We should select rather than doing all the tests. And in addition, the coagulation laboratory should be controlled by doing the regular internal and external quality controls. If there's a problem, we have to always refer complex cases to specialty laboratory. So first of all, I thought of talking APTT because we face a lot of problems which gives variable results. This is because of the reagents we use. In Sri Lanka, when I was a student at NHSL, we used to use, even up to now, Pathromptin SL reagent, that is Siemens reagent. It's an excellent reagent for monitoring heparin therapy because of its high sensitivity for heparin. It also detects all the factor deficiencies. Excellent factor sensibility permits safe detection of clinical disorders as well in the intrinsic system. Pathromptin is, but the problem is it's moderately sensitive to lupus anticoagulant. So when we do Pathromptin APTT, we will find 40, 42, like slightly elevated APTT. Usually we get referrals for those and we do a lot of workup on that. And this is because of the Pathromptin reagent property of moderate sensitivity to lupus. So, but still, this is a great, great reagent and precision, and it fulfills all the requirements. So it was able to survive all these days in spite of this problem. So CAP, that is College of American Pathologists, did a survey on these reagents, the APTT reagents, because of this problem. So lupus anticoagulant responsiveness and the reagents are tabled here. You can see the highly sensitive reagents are Siemens Actin FSL. For our NHSL, we use this reagent for our lupus testing. So you will see, normally you refer us to lupus APTT high, but in your lupus report, the our APTT is even more higher. That is because we are using high sensitive lupus reagent at that time of testing a special test. We use actually, sorry, Beckman-Coulter Hemosil APTT SP reagent because our machine is ACL top machine. So this Pathromptin SL is intermediate responsive, and the Stego STAPTT LA is another reagent which was used in a private laboratory and created problems. We got higher APTT and people started complaining why high APTT and so on. That is because of this LA responsiveness. Beckman-Coulter Hemosil Synthyl A SIL is the other reagent with intermediate properties. The low sensitive ones are Siemens Actin FS and Stego CK Press. Teco reagents are also available. Currently at NHSL, we use for routine test the Siemens for detecting the APTT for patients who are waiting for surgeries. We should use a low responsive reagent. So this is the reagent currently we are using. Anybody can have this reagent because this is available at MSD at the moment, Siemens Actin FS. So it's a low sensitive. So when you do higher result APTT with this low responsive reagent, you get a normal APTT value. It's same with the Stego CK Prest. This is used for Stego machines only. So this is the responsiveness. Then that CAP study recommendations were for the routine laboratory APTT, we should use the reagent that exhibits low responsiveness to lupus anticoagulant. Multiple phospholipid-based clotting assays, some of which may be APTT-based, are required when lupus anticoagulant screening is undertaken. When we are doing a lupus anticoagulant test, 2 tests should be performed. In NHSL, we do KCT and lupus test, but KCT is outdated now in most of the countries. KCT they don't do now because of the cumbersome, and it's difficult to perform the KCT test, but still we are doing. Instead of that, we can use highly sensitive APTT reagent as the second test. So we do that also. So we have actually 3 tests. So without 2 tests, they say not to say that lupus screening is valid. So further education of laboratory professionals and the coagulation reagent manufacturers is needed to address this clinical issue. So I think now you can understand why sometimes the APTT is 42, 45, and when we do with the lupus insensitive reagent, they become normal and you can go ahead with the surgery. So how to handle high APTT? This is for our junior doctors. Actually, you should use a 21 gauge needle for sampling for coagulation test. Vacutainer needle is 21 gauge. We use the green color needle, which is 21 gauge. Even up to 23 you can use, but this is the recommended needle. So direct venipuncture is recommended rather than taking from cannulas or lines. So quick mixing, very quick mixing with the citrate necessary, 1:9 ratio always maintain, citrate and blood, and transport to the lab within 2 hours. Do not collect in the collecting centers and send the samples. The patient should go to the laboratory where the test is done, and the sample should kept upright position during transportation. And after the receiving at the lab, the double centrifugation is necessary. This is usually 2,500 to 3,000 RPM. 15 minutes you centrifuge the sample and separate plasma and put it into another clean tube and then again centrifuge. This is the double centrifugation. For all the special tests, even lupus, we must do double centrifugation. Routine test, it's difficult. So we do not do that. And that will give rise to platelet poor plasma, that is we call PPP. So repeat the test with accurate blood collection if your APTT is high. And then the vitamin K for 3 days, and then repeat the test. Vitamin K is available oral as well as IV. Oral tablets are only available in Colombo, but if you are from if it's not available, you can use IV preparation sublingually or as a liquid. You can give, because giving IV at home is difficult. So repeat the test before sending to a referral center, and check with the lupus insensitive reagent also. Then we go for factor correction and assays. Right. Now about, Now about hemophilia, practical aspects. Actually, I am going to read out the Sri Lanka College of Hematologists guideline, which we prepared in 2020, because no one from when we ask questions from registrars, they haven't seen this guideline at all. So that is the reason I am talking about this today. So please download it from your, read it please, because we have to update it regularly according to the requirements. So few facts only I am mentioning here. First of all, we have to diagnose the patient with the fact hemophilia A, B, or von Willebrand disease. And there's actually problem. I'll tell you the practical problem we are facing at the moment. We have a cardiology patient who had mild hemophilia, and now we have to revise his diagnosis because when he's receiving for five stents, he started hematuria, epistaxis, and the dental bleeding, all mucosal bleeding, and this gave the query of von Willebrand disease. Still now we are giving him von Willebrand factor, and cardiologists want to give aspirin, so both together, and now he's responding very well. So we have to revise the diagnosis and categorize the severity. And please register these patients. When you find a patient in the ward, please register in the hemophilia registry, because every year we have to send the data to World Federation of Hemophilia. And then hematuria, always you have to hydrate the patient before thinking of giving factor 3 liters per meter squared. Because if you give straight away factor, even patient take at home, this blood getting clotted. Blood clotted inside the nephrons as well as the kidney pelvic area, and this then this clotted blood will get calcified, and they will get later on the stones and the sometimes hydronephrosis like complications. So you have to continuously hydrate, and even after 3 days, then you have to think of giving factor. Inhibitor testing is also advised prior to major surgery or invasive procedure, and round off the dose always to minimize the number of the vials we use. This is therefore even enoxaparin also. Then the frequency of administration. At NHSL, we always give once daily because of our practical issues that depend on the consultant's wish. Even the once daily is fine. There's no complications. So tranexamic acid try to use as possible, because 25 milligram per kg, that's a wonder drug which is very useful to prevent bleeding in these patients. But you should avoid it in hematuria, pharyngeal bleeding, and recent DVT patients. Then the indications for inhibitor testing, this is from the World Federation of Hemophilia guideline. So after initial factor exposure or intensive factor exposure, initial factor usually at LRH this is happening. Then the intensive factor exposure for any surgery after 5 days, we should repeat a inhibitor screening. And the recurrent bleeds or target joint bleeds, despite adequate clotting factor concentrate replacement therapy. And for failure to respond to adequate CFC replacement therapy, if you notice there's no good response, we must look for inhibitor. For lower than expected factor recovery or half-life after clotting factor concentrate replacement. And for suboptimal clinical or laboratory response to CFC replacement therapy. Before surgery, also we have to definitely do. For suboptimal post-operative response to CFC replacement therapy. Something went wrong. Yeah, all right. Right. About a few points about inhibitor. The inhibitor screening we do in our all laboratories We were using 6 at and after difference as 6 seconds recent years. Now we have increased it to 10 seconds, the difference. This is after Dhammika and myself had a training at Sukesh Nair's laboratory at CMC Vellore. We changed this to 10 seconds because they are using it's 10 seconds because 6 seconds is so narrow and sometimes we made mistakes. Therefore, it's considered. Please apply this in your laboratories also. And the definition for positive inhibitor is Bethesda titer of more than 0.6 for factor 8 and 0.3 for factor 9. If it's less than say 0.54, those are negative results. A low responding inhibitor is an inhibitor less than 5 VU, or high responding inhibitor is more than 5 VU. Everybody knows that. And FEBA should be administered according to, this is from our guideline SLCH, not according to the leaflet recommendation, but we can use 20 to 50 IU per kg because FEBA 1 mile is 1,25,000. So if you use a large number, the cost is very high. We can manage with this low dose as well. As most patients respond to lower doses, initial administration of 30 and then tail off in subsequent days. FEBA should not be given for emicizumab patients. If the patient is emicizumab, we have to use factor 7 for their bleeding control. So these are the few facts. This is also the SLCH guideline table. I'm not going to go through the whole thing, but for joint bleed, spontaneous bleeding, 20 to 40%. We usually give 30%. Daily or BD dose, you can see 1 to 2 days. This is actually after discussion, World Federation of Hemophilia, low income country charts and our discussion, the final recommendation by the Sri Lanka College of Hematologists. So the muscle bleed, same dose, but 2 to 3 days. Iliopsoas, you can say day 1 we give a higher dose, but subsequently we reduce the dose. Maybe we might go for 5 days. But CNS and major surgeries, we have to go for 100 or 80%. So now there's a problem with vaccination these days for hemophilia patients. COVID vaccine also necessary. So COVID vaccine, they don't give like that. If IM route must be the route of administration, please injection before the vaccination. Preferably with the smaller gauge needle, but you can't in community vaccination, we can't request these things. But tell them to use a dose of tranexamic acid prior to the vaccination, preferably throughout the day, 24 hours, 8 hourly. Ice pack, if possible, keep before giving 5 minutes before the injection, and tell them to keep pressure on the site of the injection at least 10 or 15 minutes, even more, to prevent hematoma formation. So there's another thing, a case presentation, one of our patients' surgery. We did it in December. He's a 44-year-old man, businessman, minor businesses, presented with lump in the right lower limb, just below the knee. It was there more than 1 year. He was trying with factor and physiotherapy and various other methods, but it didn't work. So X-ray showed that it's a pseudo tumor. And he was on factor 8 prophylaxis for 7 years up to date. And there was no inhibitors. Then orthopedic referral was done, and they did a CT, X-ray, various things, and came to a conclusion, pseudo tumor with high vascular supply to the site. So they gave 2 options. First one was actually the amputation. Patient didn't like, even I didn't like. So we requested for knee replacement. Then they said that then he need a longer metal device, not like the usual knee replacement device. Surgeon also got opinion from his friend in Australia because this is an unusual thing for him. So finally decided for knee replacement. Yeah, so this is the pseudotumor. You can see clearly here in the MRI. The holes are there in the tibia. It's lower down. That was the problem. So this is Dr. Sayantan provided me these pictures because he was present for the surgery in the theater. You can see the hole and the jelly-like material they have taken out from the pseudo tumor. So this is the post-operative picture. You can see the device in the X-ray. It's a very long one. This cost about 7.5 lakhs, 6 lakhs paid from government, but patient also paid 1,50,000 because of some issue. So this is the factor consumption during surgery. You can see the darker color one, 5433. We had to give for 16 days. 2nd of December we started, and 18th of December we completed the surgery. The upper line is the morning doses. You can see after 5th day we didn't give in the evening, except on 14th of December he went for reopening to remove another blood clot. That day we have to give little more. Even lower doses I would have used, but we were scared. Therefore we used 100% on the first day. It took 6 hours to do the surgery. With 5, we gave four vials just before the surgery on the table. We give that way now. We don't give even half an hour before. Sometimes surgeries get delayed. Then the factor get wasted. Therefore, on the table by the anesthetist, they inject the factor. And midway also, we gave another vial in case to prevent bleeding. So you can see, and he is now doing very well. Anyway, the knee replacement, the knees are can be used for 10 years, the lifetime. Therefore, for younger patient, we cannot recommend knee replacement. After 10 years, no guarantee, but now better equipments, I mean the knees are better. So sometimes they say up to 15 to 20 years they can keep. After 10 years, there's osteoporosis around the knee replacement site, and they have to replace the knee. Therefore, younger patients, we do not recommend. I think I completed this. This is the photograph for emicizumab receiving patients and our day unit team with the doctor. So thank you very much.
Thank you, dear madam, for sharing your experience and expert knowledge with us. The last presentation will be presented by Dr. Uttara Saratkumara, Registrar at NHSL, and Dr. Aindrini Mohandram, Registrar at Faculty of Medicine, Colombo. They are going to talk about a knight in shining armor. Over to you, Dr. Uttara.
Thank you, Dr. Pavasara. Good morning, everyone. Today we are going to speak of a knight in shining armor who can fight against all sorts of enemies to rescue you from danger. At the end of the presentation, you will realize who that it is. Our patient is a 79-year-old man with well-controlled hypertension with an incidental finding of leukocytosis and lymphocytosis during a medical checkup. On examination, there were few shorty cervical lymph nodes with a mild splenomegaly of 3 centimeters below the costal margin. Other examination findings were normal. His initial full blood count shows moderate leukocytosis with the lymphocytosis. Hemoglobin was normal and mild thrombocytopenia. In the ultrasound scan, abdomen showed mild splenomegaly of 15 centimeters. There was no paralytic lymphadenopathy. The blood picture is in favor of a CLL, and we went ahead with the peripheral blood flow cytometry, which confirmed the diagnosis of CLL with a score of 4 out of 5. So the diagnosis was chronic lymphocytic leukemia, and he had only lymphadenopathy, lymphocytosis, and mild splenomegaly. So his staging, delay stage A and rise stage 2. These are the treatment indications according to International Working Group of CLL 2018. And in our patient, there was no treatment indications. So we decided to observe him without any assessment of lymph node size, appearance of a new lymphadenopathy, spleen size, and the full blood count for lymphocytes doubling time. Then after 2 years, there was significant weight loss, more than 10% within 4 months, associated with fatigability. There was increase of lymph node size, but no significant increase of splenomegaly. And his lymphocyte count gradually increased over last 2 to 3 months with marked leukocytosis and lymphocytosis with moderate anemia and mild thrombocytopenia. Retic count was normal, that was negative, and infections were excluded. And this time, there were 2 treatment indications for him: progressive lymphocytosis with an increase of more than 50% over 2 months and constitutional symptoms. So before going to treatment, we performed a bone marrow biopsy which showed nodular and interstitial lymphoid aggregations composed of small mature lymphocyte cells accounting for about 40% of the marrow cellularity. And the TP53 was negative. IGHV test not performed because of the financial issues, and the other investigations were normal. So Angrini, what are the treatment options for him?
Yes, Uttara. The treatment of CLL is mainly determined by the TP53 status as well as the patient fitness. Many studies have shown inferior outcomes with conventional chemoimmunotherapy for patients with TP53 disruption. Therefore, targeted therapies like BTK inhibitors, venetoclax, and PI3K inhibitors have become the standard of care for them. But there is still some place for chemoimmunotherapy for patients without TP53 disruption, which the choice is mainly determined by the patient fitness. So talking about our patient, his TP53 is not disrupted, and we don't know about his IVHV mutational status. He's almost 80 years. And talking about his fitness, his ECOG is 2, which is good, but CIRS score is 5, and there is moderate restriction of activities of daily living, and he's using a walking stick for mobility. So he's not definitely fit for high-intensive regimes like FCR. So what are the treatment options available for our patient? Historically, for someone who is older and less fit, the main treatment option was chlorambucil-based regimes. In this CLL11 trial, they have compared chlorambucil monotherapy against chlorambucil rituximab versus chlorambucil obinutuzumab. And you can clearly see in the Kaplan-Meier plots on your left, addition of anti-CD20 antibodies to chlorambucil had clearly improved their progression-free survival as well as overall survival. Out of the 2 combinations, chlorambucil obinutuzumab provides better response rates as well as progression-free survival benefit compared to chlorambucil rituximab. So among the chlorambucil-based regimes, chlorambucil obinutuzumab carries the best outcome. So apart from these chlorambucil-based regimes, in the MABEL study, they have compared rituximab and bendamustine against chlorambucil rituximab and have shown progression-free survival benefit, but there was no significant overall survival benefit. And importantly, grade 3 and more adverse incidents were higher in BR-treated patients than chlorambucil rituximab treated patients. So for someone who is 80 years and with moderate CIRS score, and apart from this, he was the only caregiver for his wife who was suffering from a rheumatological disease with significant joint mobility. So for such patient, even though BR carries better outcomes, must not be a good option for our patient. So the next question is, are there any better options than conventional chemoimmunotherapy? And the answer is yes, because targeted therapies have emerged even in front line, even for patients who is older and less fit like our patient. This is the RESONATE 2 trial where they have compared ibrutinib against chlorambucil and had shown overall survival benefit. This is more important trial, which is an with ibrutinib. And in the same trial, they showed that addition of anti-CD20 antibodies to ibrutinib has no significant benefit comparing to ibrutinib monotherapy. So venetoclax is the newest addition for the targeted therapies, and the CLL14 trial compared venetoclax with obinutuzumab against chlorambucil obinutuzumab combination and has shown superior outcomes with venetoclax in frontline CLL patients with coexisting condition. And these trials had shown better MRD negative rates with venetoclax, almost reaching 75%. If we compare this data with ibrutinib, even though ibrutinib is very effective in ibrutinib is very effective and carries better progression survival and overall survival benefit, the MRD negative rates are very low with ibrutinib, and they don't even recommend monitoring MRD after ibrutinib therapy. But with venetoclax, the MRD negative rates almost reach 75%. And in subgroup analysis, you can see in the Kaplan-Meier plots on your right, the patients with TP53 mutation who was treated with venetoclax and obinutuzumab, their progression-free survival curve overlaps with the patients without TP53 mutation treated with chlorambucil obinutuzumab. Therefore, the benefit of venetoclax seems to be less in patients with TP53 disruption. But to remind you, venetoclax is recommended for treatment of TP53 disrupted patients with CLL because its outcome is far better than normal conventional chemoimmunotherapy, but the beneficial effect seems to be less in TP53 disrupted patients compared to patients without TP53 mutation or deletion. So in summary, targeted therapies like ibrutinib and venetoclax seems to be the best option for us, our patient, because they are shown to be more efficacious and less toxic. But even though the world is moving fast, most of these options are not available for us. So we had to settle with chemoimmunotherapy, chlorambucil, and rituximab. Again, not the best one, but fairly reasonable one for a patient without TP53 mutation. And Uttara will now tell you about his journey with chlorambucil rituximab.
We decided to go for immunochemotherapy, and as we do not have obinutuzumab, we treated him with rituximab and chlorambucil 20-day cycle regimen. Rituximab 375 milligram per square meter and chlorambucil 10 milligram daily from day 1 to day 8 of each cycle. And because of his lymphocyte count is more than 25,000, we in the first cycle, we gave him the rituximab dose as 2 divided dose, the small dose on day 1 and the rest on day 2. And from second cycle onwards, we continued the whole dose as a daily dose. And acyclovir and fluconazole given as supportive treatment. 6 cycles completed, and our treatment was interrupted after 5th cycle for 1 month due to neutropenic sepsis, which we treated with GCSF and broad spectrum antibiotics. This slide shows how his full blood count changes during treatment. And as you can see, the WBC count along with hemoglobin and platelet, there's improvement until 4th cycle, and later on, the response seems to be lost. And there was no improvement in clinical symptoms either. So this is the count at the end of the 6th cycle. This time also we did a DAC, which was negative. And then we assessed the patient with a bone marrow biopsy, which showed diffuse infiltrations of small lymphocytes accounting for about 70% of the cellular activity. And TP53 done, which was negative. So Irene, what are the options for him now?
Now the patient is not responding to chemoimmunotherapy. Therefore, obviously, targeted therapies are the first line in relapse setting of CLL. And both ibrutinib and venetoclax have shown their place in relapsed and refractory CLL. This is the RESONATE trial where they have compared ibrutinib versus ofatumumab in the relapse setting. And look at the response rates. In patients with a median number of prior therapies of 3, the overall response rates reach 82.6%, which is very promising. And the venetoclax and rituximab combination was also trialed in relapse setting in this Murano trial, again had shown progression-free survival and overall survival benefit over bendamustine rituximab. And in this trial also, they have shown higher undetected MRD negativity in patients treated with venetoclax rituximab. PI3K inhibitors like idelalisib is also an option for this our patient at this setting, but post-pharmacovigilance trials have shown higher rates of severe pneumonitis, hepatitis, colitis, and serious infections with PI3K inhibitors. Therefore, they are reserved for patients who are not eligible or refractory to ibrutinib or venetoclax. So what is the best option between ibrutinib and venetoclax? Both the drugs have their pros and cons. If we think about ibrutinib, the main drawback of ibrutinib therapy is it's an indefinite therapy, whereas venetoclax is a fixed duration treatment. But venetoclax is IV administration needing hospital admission. Ibrutinib is just swallowing 3 pills a day. And as we discussed, there is more MRD negativity achieved with venetoclax compared to ibrutinib, and less efficacy was shown with venetoclax in patients with TP53 deletion or mutation. And one special thing about ibrutinib is it is universally effective irrespective of the TP53 status. And we have longer follow-up data on ibrutinib, whereas only 4-year follow-up data is available for venetoclax. So after giving the options to our patient, luckily he could afford for a costly treatment like ibrutinib indefinitely. Therefore, the patient was started on ibrutinib. And Uttara will now tell you his journey out from dark into the light.
Then he was started with ibrutinib 420 milligram daily dose with acyclovir. And after 2 weeks, we performed a full blood count, which shows marked increase of WBC count with 95% of lymphocytes. When the WBC count is rising, we started him on allopurinol, and we performed tumor lysis screening panel, which all came normal. Then even after 1 month, when we performed another count, full blood count, in the full blood count, WBC count is still in rising trend. So is he not responding to ibrutinib?
Yes, after boasting everything about ibrutinib, now one might think that the patient is not responding. But fortunately, that is not the case. Because treatment-induced lymphocytosis is a well-recognized class effect of BTK inhibitors, and it is thought to be due to efflux of tumor cells from the tissue compartments into blood. For cell-cell interaction between CLL cells and in the tissue compartments, in BCR signaling pathway is important. So when you inhibit BCR signaling by inhibiting gluten tyrosine kinase, the interaction between addition molecules like CXCR4 and STF1 is also inhibited, leading to cell mobilization from tissue compartments into blood. And in majority of the patients, lymphocyte peak was seen within 24 hours of initiating therapy, and the median duration of lymphocytosis was 8 to 24 weeks, depending on different studies. And in majority, this lymphocytosis resolved within 8 months, but in a subgroup of patients, that may even last beyond 1 year. This is an interesting review article which was published in Blood by Jennifer et al., where they have studied the molecular characteristics of these lymphocytes in detail. And they have shown that gluten tyrosine kinase remained inhibited in these lymphocytes after therapy. However, the signaling pathways downstream to gluten tyrosine kinase is still active, responsible for their survival. But they confirm that proliferation is absent in these cells and there is no evidence of new recurrent mutations. Or interesting thing about this is that patients with persistent lymphocytosis, even beyond 1 year, had trend towards better progression-free survival. You can see in the Kaplan-Meier plots, the upper straight dotted line is from patients with persistent lymphocytosis beyond 1 year. So they have trend towards better progression-free survival. Even though confirmation of this data with larger sample size is needed, this indicates that persistence of a crescent CLL clone may inhibit resistant subclone formation or expansion, and with ibrutinib, the elimination of MRD or even elimination of gross disease may not be necessary. And this also highlights need for revised consensus response criteria in CLL to prevent unnecessary drug interruptions, because more and more patients will be on ibrutinib, and the current consensus criteria requires normalization of lymphocytosis after treatment for complete remission. Apart from this treatment-related lymphocytosis, atrial fibrillation was one major side effect of ibrutinib, which was reported even more than 10% of patients in some trials, and hypertension and hemorrhage is also shown to be the common side effects of ibrutinib. And ibrutinib was shown to have antiplatelet effect, so hemorrhage is one major problem in there. So all this time we discussed about ibrutinib's place in someone with CLL, a patient with older and less fit patients. But what about its place in young and fit patients with CLL? This is a groundbreaking ECOG trial which was published recently. Where, and look at the trial, look at the title of the trial: ibrutinib rituximab or chemoimmunotherapy for CLL, because they have compared ibrutinib against the best available chemotherapeutic regime, FCR. And overall, in all subgroup of patients, there was clear outcome benefit with ibrutinib compared even to FCR, except for this small subgroup of patients who are fit for FCR, but with TP53 undisrupted, but IGHV mutated patients. So after this trial, if we see treatment recommendations for CLL, you can see ibrutinib everywhere, whether it is frontline therapy or relapse setting, whether it is fit patients or young patients, except for the small subgroup who are eligible for FCR, but with TP53 undisrupted and IGHV mutated patients, where FCR could be rationalized over ibrutinib. So that is why we called it a knight in a shining armor, because we always have this dream of a handsome young man who is running on a horse when you're in danger, leaving behind the rest of the world, and who could fight bravely against any sort of enemy to rescue you from danger. And ibrutinib is one such knight of shining armor for patients with CLL. Not only in CLL, ibrutinib has shown its efficacy in other B-cell malignancies as well, like mantle cell lymphoma and lymphoplasmacytic lymphoma, especially in the relapse setting. So when you're a hero, you always have challenge and competition, but challenge and competition makes you a better person. So they have developed new BTK inhibitors, which have more specific kinase activity to minimize the side effects. And acalabrutinib and zanubrutinib is also already FDA approved for treatment in CLL. And when you're too good, and when people can't directly fight you against, so they find different ways to overcome your talents. Likewise, BTKI resistance is also reported by developing mutations in ATP binding site of the Bruton tyrosine kinase. And now the studies are ongoing to look the effectiveness of non-covalent BTK inhibitors like LOXO 305 in overcoming this BTKI resistance. And the newest trials are trying to combine ibrutinib and venetoclax to see whether hitting hard and achieving MRD at front line will lead to fixed duration treatment. So world is moving very fast, and the future is becoming more and more promising for these patients. So we sincerely hope that more and more of our patients will be as safe and as comfortable as this young princess with our knight in the shining armor. And last, I would like to thank Dr. Lalindra Gunaratne for introducing him to us, and thank you for your patient listening.
Thank you, Dr. Indrini, for that excellent presentation. As there are no questions in the Q&A box, that brings to the end of the first red box in year 2021. I would like to hand over to Dr. Manuri Prabhashika to conclude the session. Thank you.
this comes to the end of the first red box of the year 2021. On behalf of the Sri Lanka College of Hematologists, I would like to thank all the presenters, especially Dr. Rajita Samarasinghe and Dr. Vishaka Ratna, and sharing their knowledge and experience with us. And I would like to thank all the consultant hematologists of the respective training clusters, Colombo cluster and Ragama cluster, for their guides event a success. I would like to thank especially the senior registrars of the two clusters, Dr. Madhwanti and Dr. Pavasara, for coordinating these events. And again, I would like to thank the President and Council of the Sri Lanka College of Hematologists for organizing the event. My special thank goes to the technical team for their technical support to make this virtual event a success, and also the pharmaceutical company Sidus for sponsoring this event. Last but not least, I would like to thank all the participants for joining this event. So this comes to the end of this red box, first red box of this year. And this year we are hoping to conduct 2 more red boxes for the other training clusters. Thank you all.